Imagine that you had to give up function, the ability to speak or eat normally, your facial appearance. What would you say? So we're going to look for some ways to do things that are a little less aggressive and offer up some less invasive alternatives for when there are options. You told me many of you like Grey's Anatomy, and lots of us like medical shows because we find medicine interesting. Because medicine offers us the hope that ourselves and the health of our loved ones can be maintained. Also, medicine is dramatic. It's life and death, love and hope. My 9 colleagues and I at the University of Miami's Sylvester Cancer Center are cancer surgeons, tumor specialists from the field of ear, nose, and throat. We handle tumors of the head and neck tissues, except for the brain and the spine. And no, I don't really work with Dr. McDreamy. But I am very passionate about this field. So, what can we do to limit the collateral damage of surgery? This video clip from Grey's Anatomy offers us a window into the difference between radical and minimally invasive surgery. Just to make it clear, there's no real surgery like the first one you are about to see.
Scared? Well, there's not any blood, nothing gross, nothing scary. It's just 3 tiny tests that are so small, you barely see them.
That guy's face go.
You lost him, Allie?
Sorry.
No, wait, I want to see the guy with the face. Stop.
Whatever you want. Okay.
Okay.
Good afternoon, Duncan. Come on in and take a look.
Go back to the other one.
We're not talking about that.
This one's boring.
Yeah, well, yours would be boring too.
We react emotionally to issues in the face and neck area, don't we? Because this is the part of the body that we use to interact with others. We communicate through speech, facial expression. We share meals with our loved ones. This is the part of the body we use to face the world. Head and neck cancers are actually not rare. If you lumped them all together, because there's so many different sites, it would be 500,000 cancers annually in the United States, more than any other site. Furthermore, there's a new epidemic, an epidemic of a new kind of throat cancer caused by papillomavirus in non-smokers. So what made me choose this field? Well, certainly, head and neck offered the opportunity to deal with complex anatomy, nerves, blood vessels, arteries, and I was excited by the fact that significant cure rates could be achieved in treating these tumors, particularly with early detection. But so many of our patients deal with either deformity or dysfunction in swallowing or speech. And you might think that would discourage a young physician from going into this field. Yet, the bond that I found between the head and neck professionals and the patients they were caring for was among the closest bonds I witnessed as a medical student and resident of any of the bonds in medicine. The patient has to come back and see the doctor every few months at regular intervals because the head and neck surgeon is the only one able to examine all the passages of the nose and throat and mouth. But those visits become much more than screening examinations. We've shared with that patient what might have been the most difficult time of their life, and that creates a special bond. And this bond that I witnessed in my head and neck teachers really is what drew me to the field. It is important to point out that the effects of the uncontrolled cancer are much greater than any side effects of treatment could ever be. Ulysses S. Grant was the only US president to die of cancer. The dramatic story of his last year of life, as he raced to complete his memoirs, is widely described as Grant's last victory. It is poignant to note that Grant, who led the Union Army, was president of our nation, was isolated by his disease. "I have such difficulty speaking that I am no company," he said. His illness and his inability to speak and eat created a boundary that separated him from his many friends and admirers. Grant finished his book, which is widely recognized as among the best memoirs of a world leader. A quote from Grant can really shed light on what we were talking about earlier, the close relationship between the head and neck physician and their patient. And I'd like to read that quote to you. "The friend in my adversity I shall always cherish most. I can better trust those who help to relieve the gloom of my dark hours than those who are so ready to enjoy with me the sunshine of my prosperity." As we move forward to talk about treatments and better ways of doing things, let's keep in mind that it's real patients in need who are the motivation behind this process. Okay, so let's go back in time now to the time of my great-grandparents, when general anesthesia was just invented, making surgery possible. One of the first head and neck operations to be described was in the 1880s by Theodore Billroth, who described the removal of the voice box, also known as total laryngectomy. Schematically shown here, the total laryngectomy eliminates the connection between the windpipe and the throat through the larynx and vocal cords. The trachea, as seen in the diagram on the right, is sewn directly up to the skin, end to end. To speak, the patient now needs either a valve or a new sound source to vibrate the air in their throat, and they breathe out this permanent opening in their neck for the rest of their life. Okay, so some surgeries were possible, but over the next 20 years, as these were developed, surgeons realized that cancers were coming back, and they did not know why. William S. Halsted, the father of modern surgery, developed a few principles that changed everything. First of all, he realized that the real boundary around a tumor was not the lump, but that actually there were microscopic cells in tissue a greater distance around it, and a margin needed to be removed. He also noted that cancers could spread in our system of tubes and filters, known as the lymphatic system, the lymph system. Here you see a tumor on the surface, invading down, going into a lymph tube, where it will eventually get stuck in the filter, the lymph node. These principles allowed for better cure rates, but it also led to overcompensation. Surgeons figured if taking a bit more was getting better results, maybe they should take a lot more. Fast forward now to Hayes Martin. Hayes Martin was the chief of the world's first head and neck unit, which was at Memorial Hospital in New York. He applied the principles of Halsted with great success, but with great side effects. He developed an operation that removed a piece of the tongue for tongue cancer or a floor of mouth cancer, along with a piece of jaw and a radical removal of tissue in the neck. You have to imagine this was a gutsy thing to do, and if you look at his eyes, you can see he was a determined man to cure these patients. But yet, this created a great deal of difficulty with speech, swallowing, and eating. His team referred to this as the Commando Procedure. Here's an example of a recent tobacco ad which shows a patient who's had this procedure with no reconstruction. You can see he's missing a portion of his jaw. Obviously, that patient can never chew. Okay, let's fast forward again to 1986 and the beginning of my own medical career. At that time, tumors of the mouth and throat are still being accessed by dividing the lip and jaw, something akin to the Commando Procedure, and still experiencing the swallowing and speech side effects that we spoke about. In addition, lymph nodes in the neck are removed through a radical removal of tissue, including nerves and muscles, known as the radical neck dissection. But here's the key. They were doing this when there was no cancer in the neck visible or evident, just because of the possibility of microscopic spread. It was effective, but it led to shoulder dysfunction and scarring. Okay, so let's now talk about a real patient. Obviously, President Grant had no chance in the mid-1800s. There was no general anesthesia. There was no technology. But I'd like to tell you about a real patient, a teacher, 40 years old. We'll call her Mrs. Smith, who presented early in my training. She had a tumor in the back of her tongue, a cancer, which by the time she came in that summer had progressed to be about an inch in size, a hard ulcerated mass. Surgery for her at this time, if she had presented in the mid-1980s, would have been something like the Commando Procedure with the radical neck, and she had a high chance of cure. But that extra cut in the floor of mouth might keep her from speaking normally and could end her teaching career. In addition, she would have a scar on her lip, damage to her jaw. She would have to wear a tube temporarily to get her through the surgery that would go through the skin into her windpipe, a tracheostomy tube. And she would need a feeding tube and months of swallowing therapy. But Mrs. Smith didn't actually present in the mid-1980s. She actually presented in 1991. And a little bit of progress made a big difference, because now a new professor in head and neck surgery at my residency was developing a new operation called the transhyoid approach. And if you key in on this little area right here, that's the window that was used to remove the tumor not through the jaw, but looking backwards through a window behind the tongue. We actually wrote a paper comparing this to the Commando Procedure, which the term had fallen out of disfavor, and different terms were used, but we compared it and found excellent results, no infections of the jaw. And this was the operation that was offered to this patient. Now, she still would need to go through a lot. She would still need to have a tracheostomy. She would still need a feeding tube and lots of swallowing therapy. But she wouldn't need that cut in her jaw. She wouldn't need that cut in the floor of her mouth. And guess what? Her speech would return to normal. And next year, a year later, she was able to resume teaching. Okay. So what would happen with a patient like this if they came in now, in 2015? Our specialty has new tools, a new focus, and the most radical procedures are now reserved for patients with the largest tumors or recurrences. And I'd like to tell you about some of the technologies that we now have available. Here you see a surgeon looking through a microscope into a patient's throat. Over here is where the laser is attached. And this depicts endoscopic surgery. What does that mean? Endoscopic means taking the tumor out from the inside through the natural opening of the mouth or nose. So when you do an approach, obviously to get there, like through the jaw or through the neck, you have to do damage on the way in. But when you take it out through the inside, patients get much better results. They swallow better, they speak better, and they don't have to go through extensive rehab, have tracheostomy tubes, feeding tubes, etc. And not only do we use the laser, we also sometimes use the robot. The robot allows us to take this tumor out from the inside and not do the damage even that this window procedure would have caused going in from the outside. And the way it does that, and this is a depiction of a patient's throat, and here you see the tongue, the patient's lying on their back obviously, so this is the little bell that hangs in the middle in the back of your throat, and here's a tumor of the tonsil, and this view is similar to one you're going to see in a surgery video in a minute, just to orient you. You can see there's lots of nerves that go to the tongue and the throat that you got to be able to get in there, manipulate, go around corners, and get that tumor out without hurting these arteries and nerves or managing the arteries if you need to. And by doing that, the tumor cuts, so if you see here, the tumor cuts around that tumor are the only cuts. There's not a cut to get in. Here's a depiction of the removal of a sinus tumor, a sinus cancer, directly through the natural opening of the nose. You can see the surgeon looking at the television and working with instruments, a scope in one side of the nose, instruments in the other side of the nose. And this is actually the brain, seen through the natural opening of the nose after removal of the tumor without any external incisions, working only from the inside. Frontal lobe, This is the brain. It's a tumor has been removed that came just below the smell nerve as it comes into the nose. And here, on the next view, you see the reconstruction that separates the brain from the nose. Okay, let's go back to talking about the robot, which was pioneered for head and neck surgery at the University of Pennsylvania. The robot's hands are small. It's only an index finger and a thumb, and it's only the size of an eraser. So it can fit into any little hole in your mouth or throat, and it rotates in 3 dimensions just like our wrist. It's a wristed instrument, can work around corners, and if you look over here, the telescope is also angled, and you can change telescopes to one with a different angle so that you can look around corners. Here's a video taken from YouTube of a surgeon using the robot to peel a grape. And the idea of this video is simply to show how delicate this instrument can be. Or maybe he just wanted a grape, I don't know. But anyway, this is now an actual surgery done with the robot, one of our surgeries. The surgeon spends a little time at the head of the patient, and then the assistant moves to the head of the patient. And the surgeon actually spends most of their time sitting at a computer working the robot. This is the view that you see on the screen is the same view you saw on that other video. So the tonsil cancer is down here. The thing that hangs in the middle of your throat, the little bell, is right here. And so we can go right up to the nerves, the blood vessels, and we'll be able to see them with this technology and work around corners. Another new technology is something called Sentinel Node Biopsy. So this doesn't address the primary tumor of the mouth or throat or the skin. This addresses the lymph nodes. We talked about the radical neck dissection, and there's also modified radical neck dissections where you take a 7-inch piece of tissue that might have 40 to 60 lymph nodes in it, and you're doing that because you're looking for hidden cancer and doing it in patients who might not even have cancer in the lymph nodes. And so this is a much more selective way to get that information. So there's many lymph nodes in the neck, and the way the procedure is done is you inject the primary tumor with a radioactive material, a radiotracer. And that radiotracer is the right particle size so that it actually goes into those little lymph tubes I showed you earlier and drains down to the lymph nodes and gets trapped in the first lymph node that drains that tumor. You can see that on an X-ray that's done before surgery, and the area that's lighting up there in the small circle is the sentinel node. It's the hot lymph node. It's taken up the radioactivity that actually started with injection at the primary site. You then take a Geiger counter-like instrument called a gamma probe, and you scan the neck until you find the small sentinel lymph node. So instead of taking out a 7-inch piece of tissue, you take out a piece of tissue the size of a peanut, and then you hold it up and make sure that that's where the radioactivity went that you injected at the primary site. And if it is, you know that's the sentinel lymph node. And that's a marker for all the other lymph nodes in the neck. You take that one lymph node out, and he's the one who tells you what the other ones had. The word sentinel means the guard or the keeper, the one who stands at the gate and keeps you from going over the moat and into the castle. Similarly, that lymph node monitors that tumor and the lymph flow coming from it. And cancer cells would get trapped there before going to any other lymph node. So if you don't find cancer in the sentinel lymph node, you don't have to remove another 60 lymph nodes and do a big operation to prove that there's no cancer in that neck. We recently took care of Renee. Her surgery was actually a year ago. And Renee had a tumor similar to President Grant's in her mouth. She underwent removal of the tumor, again, through the natural opening of the mouth using endoscopic surgery. And she underwent the Sentinel Node Biopsy procedure. This is a brief interview with her in which she describes her recovery. She's 39 years old. Her surgery was a year ago. Her biggest problem was she was so busy at work, she couldn't make time to get this taken care of.
My recovery was uncomfortable only probably for a few days. By the second day, I started to already feel much better. By the 6th day, I started to be able to eat solid food. Prior to that, it was mostly fluids. And within probably the first 7 to 10 days, it was starting to get back to normal with me being able to eat just about everything I needed to. And then my speech started to improve as well. This is what my scar looks like. If you don't look closely, you probably wouldn't see it. If I sit up, you probably would see it as a crease. So it's wonderful. It's compared to a year ago since the surgery, this looks amazing.
So, thank you. So there's still side effects, there's still limitations, but minimally invasive surgery can make a big difference for some of our patients. So how do these technologies develop? How do we get to this point? How do we make this happen? Well, through research, through studies called clinical trials that involve patients. Clinical trials, however, have boundaries too. Rules and regulations, because we can't hurt the patient of today to help the patient of the future. So we have to take baby steps as we do research. Babe Ruth, the most famous baseball player of the 20th century, had throat cancer. He was diagnosed in 1946. He set a special example by participating in a clinical trial. When asked about that participation, I'd like to read you the quote of what he said. "I realized that if anything was learned about that type of treatment, whether good or bad, it would be of use in the future to the medical profession and maybe to a lot of people with my same trouble." So to Babe Ruth and all the other countless patients who have participated in clinical research, allowing themselves to be studied to help other people, I'm very hopeful that the boundary set by our patient can be honored. Doctor, save my life, but save my quality of life too. Thank you.